Hey, today I want to talk to you about gestational diabetes. I'm not going to get into too much of the pathophysiology as the Khan Academy video talks to you about that, so please make sure that you watch that before listening to this video. So, gestational diabetes, I picked this picture because sometimes this can feel like people feel like when they get diagnosed with this, like their world is turning upside down and they are hanging on a cliff because we are asking women to think about diet and nutrition in a completely different way, and that like their world is turning upside down. And being diagnosed with a high risk pregnancy is a pretty challenging time for a lot of women. So, speaking of that, a high risk pregnancy, if we haven't talked about this yet, but I really like this quote, is one in which a condition exists that jeopardizes the health of the mom, the fetus, or both. The condition may be the sole result of the pregnancy, or it may be a condition that occurred before the woman became pregnant. And I think that diabetes is one where that is so true, because diabetes can be something that we are diagnosing oftentimes, especially if it's in the first trimester. She may have been diabetic and we don't find out until, especially if we're screening her in that first trimester, and she might be just newly diagnosed, or it may be purely just gestational diabetes. So this is really a significant condition where we can make a lot of difference in the long-term health of this person. So this is another graphic, maybe just to explain a little bit more of what the Khan Academy video did. Again, I don't want to get too much into it because you do have that to look into. But again, just considering that it is an endocrine condition, that it can complicate, it's 6 to 9% of all pregnant women, and it's where it's an insulin resistance that's created by hormones from the placenta, where you can see that, like here, the insulin is blocked from going into the placenta. Glucose then can cross over and infect the fetus, where they have hyperglycemia, and then they develop hyperinsulinemia. So I kind of thought we could use this gal as our case study for the lecture. So Jackie is a 29-year-old African-American prima gravida. She has a family history of type 2 diabetes. Her mother developed gestational diabetes when pregnant with Jackie and then was later diagnosed with type 2 diabetes herself. Jackie just began care here at 14 weeks, and her pre-pregnant BMI was 32. So think about Jackie and what you know so far of like what risk factors she might have, and what management like you're thinking you would want to do with her so far. So let's think about the difference between pregestational diabetes versus gestational diabetes and the differences between those. So right now, we know that let me back up a second. So those who have an increased risk of gestational diabetes are people who are obese, who have a prior history of gestational diabetes, who have glucose in their urine, present to the clinic with glucose in their urine, have a strong family history of diabetes, who are ethnicities of Hispanic, Native American, Pacific Islander, and African American, who have a maternal age of greater than 25, have had a prior infant weighing more than 9 pounds, a stillborn, or any poor obstetric outcome may be related to that macrosomia. So any of those things would lead you to think possibly a possible gestational diabetes. So we want to consider that, any of those risk factors with her. So thinking about Jackie, what risk factors does she have? So when we look at the influence of pregnancy on diabetes, whether it's the type 1 or type 2, so these are the ones that present to us who have a history of diabetes before they were pregnant, where gestational diabetes is those who we are diagnosing during the pregnancy. So with people who have diabetes before pregnancy, the physiologic changes of pregnancy will actually alter their insulin requirements significantly. So we know that their insulin needs will actually decrease in the first trimester. And so this can be, especially people who are on insulin, and typically midwives aren't caring for insulin-dependent diabetics. We're going to refer them out. But this is just so you know. But insulin needs decrease in the first trimester. Their HCS hormones levels are low, and so because the energy demands of the embryo is low because they're not eating much food. And then insulin requirements will actually rise early in that second trimester, around 14 to 16 weeks, as the glucose use and glycogen store by women and fetus become increased. So as the placental production and the insulin requirements can actually double and quadruple by the end of the pregnancy, and in labor their energy needs will increase, and then postpartum we'll see their after the delivery of the placenta, the insulin requirements will usually sharply decrease with the loss of HPL, with the loss of that placenta. So we see a sharp decrease in the postpartum period. The renal threshold for glucose decreases sharply with producing the glucosuria. We see an increased risk for ketoacidosis, and it can occur at really much lower serum glucose levels than you would normally see, and that's why these women are at such high risk for DKA. We see their vascular disease accelerate significantly, same with DKA. We see an increased risk for hypertension and for neuropathy from the renal impairment. So we see a lot of inflammatory and degeneration of the kidneys. So the main concern is to really, really keep their blood glucose levels in really, really tight control. And if we had women who are insulin dependent, oftentimes, even if they haven't been on a pump, this is the time that we'll get them on the pump just so they can keep that tight control. So the influence of diabetes on the pregnancy, the maternal risks that we see are hydramnios. We'll see about a 10 to 20% of women will develop hydramnios when they have diabetes, and it results from excessive fetal urination from their hyperglycemia, fetal hyperglycemia, which can lead to premature rupture of membranes and preterm labor, which could also lead to cord prolapse or abruption. We see an increased risk for preeclampsia. About 12% of women who have preeclampsia also have diabetes, in comparison to 8% of women, or 8% of preeclamptic women will be non-diabetic. We see hyperglycemia and ketoacidosis. And then preterm labor, we talked about that a little bit. We see a lot of vaginitis and UTIs in women because of the glucosuria. And that's a constant battle, which can also lead to preterm labor. And then retinopathy is a significant issue. Fetal risks with women with type 1 and type 2 diabetes. With severe ketoacidosis, we see a 50% increase in fetal death. Congenital anomalies are higher by 3 to 4% if they have high glucose in the 3rd to 6th week of gestation. So we can see anomalies of the heart. That's the biggest one that we're usually concerned about. CNS and skeletal systems, about 6 to 9% of that. A lot of that's a lot. The heart is the biggest one that we'll talk about management in an issue or a little bit with that, but the heart is the biggest one that we're usually worried about. Macrosomia is very characteristic of type 1. It's about 20 to 25% of pregnancies. And that's because of the fetal hyperinsulinism and the hyperglycemia that can lead to excessive growth and fat deposits. And insulin can act as a growth hormone in these infants, so that's why it can lead to that macrosomia. So then, because of the macrosomia, then we worry about things that can lead to birth trauma, like fractured clavicle, shoulder dystocia, other C-sections, pieces like that. So there is an increased risk of C-birth also with women with type 1 diabetes. So the crucial time really is at that 36 to 40 weeks 40 weeks because we then also start worrying about placental insufficiency and the increased size that can cause complications. And so we do a lot of fetal monitoring and antenatal testing to make sure that the placenta is working well. We worry about hypoglycemia after the delivery because of their hyperinsulinemia. Because they continue to keep producing the insulin, yet they're not having the glucose supply from mom. So I'm sure you all have heard about that already. And infants who have vascular involvements, so we've talked about macrosomia, but we can also have infants that have fetal growth restriction because if the placenta doesn't have good vascular work, because the glucose molecule is so big that it can actually start blocking the placental vessels. And so the placenta starts to decompensate and they don't get good blood flow, so then they become growth restricted. So we can actually see some of these babies become growth restricted. Mothers with long-standing diabetes, we can actually see RDS from decreased surfactant that results from high levels of fetal insulin. And then we can see stillbirth often after 36 weeks in those who have vascular disease, poor glucose control, DKA, or preeclampsia. So it's a pretty significant illness. So for management with these women, we want to get all of them in the first trimester an eye exam, and usually an ophthalmology consult. And then the ophthalmologist will make recommendations about how often they want to see them during the pregnancy. We also want to make sure that we are getting them an assessment of renal function, usually by doing urine protein and creatinine, electrolytes. I'm guessing that clinics that you work at will have protocols for these. Oftentimes in your type 1 and your long-standing type 2 diabetics, like they've been a type 2 diabetic for a certain amount of years, they'll usually want an EKG order to make sure that their heart is okay. We oftentimes will start a baby aspirin at 12 weeks to help decrease those vascular issues with the placenta. We'll do level 2 ultrasounds with a fetal echo at 20 to 22 weeks to be monitoring for any cardiac issues with baby. And we do a lot of antenatal testing, NSTs and biophysicals at 28 weeks, and growth ultrasounds at 32 and 36 weeks to really monitor that placenta and make sure that the baby is not becoming growth restricted and there's no placental insufficiency occurring. So those are your type 1 and type 2 diabetics. Gestational diabetics now are still at risk, and a lot of the management things, I'm going to go back to the slide, we'll still do with the babies a level 2 ultrasound at 20 and 22 weeks and the NST, BPP, and growth ultrasounds, but everything else we don't do with our gestational diabetics because we don't know about them until 28 weeks. Gestational diabetes are 6 to 9% of pregnant women will develop diabetes during the pregnancy. However, if for some reason we were to screen them because they met the criteria and we diagnosed them in the first trimester, they're not considered a gestational diabetic. They're considered a type 2. And I think that's really significant to understand. So they might come into the pregnancy at 6 to 8 weeks, not thinking they're a diabetic, but because of their risk factors, we decide to do an early screen on them. And if you diagnose them at that point, at that early screen with diabetes, they are not considered a gestational diabetic. They are considered a type 2 diabetic. And that is really, really key for their health after the pregnancy. So please make sure you understand that. The prevalence of gestational diabetes is higher among this list of ethnicities, and know these well. And I just put this here just to kind of once again, I don't know, I have eclampsia, sorry, I'm going to take that out right here. Diet control is considered an A1, diet A2 is needing insulin. GDM increases the risk for preeclampsia, polyhydramnios, cesarean section, macrosomia, shoulder dystocia, hypoglycemia of the newborn, and hyperbilirubinemia. And it increases the risk for developing diabetes later in life. In fact, 70% of women will have diabetes within 22 to 28 years after the pregnancy. So think about that. Within 22 to 28 years, they will have developed type 2 diabetes. So that's pretty significant, and they need to know that so that they're getting routine testing done so that they don't have undiagnosed diabetes for a significant time of their life. Even more concerning is Latina women will 60% of Latina women will have developed diabetes within 5 years of the pregnancy. So these are young women that will be living with diabetes for a significant portion. And it is so important that we, and very possibly women that we are still seeing during pregnancies and during their childbearing years. So it's very important that we are educating them and helping them take care of themselves. So when we go back to, thinking about Jackie and the risk factors that she has, would it be appropriate for us to screen her early, or would it be okay for us to wait until her 28-week screen? Well, Jackie is, she is a BMI higher than 25. She is ethnicity that is at high risk, African American. She has a first-line relative that is a diabetic. So that actually places her in a category that would be appropriate to screen her first in the first trimester. So because of her risk factors, that was what we would do. So what are the appropriate what are the risk factors for screening early? So BMI higher than 25. ACOG says that if they have a BMI higher than 25 and one additional risk factor, we should screen them early. The American Diabetes Association says it should be additional 2 risk factors, but ACOG says 1. A first-degree relative with a history of type 2 diabetes or more. If they've had gestational diabetes in a previous pregnancy, if they have high cholesterol, a history of cardiovascular disease, hypertension, if they're a member of an ethnic group with a high incidence of diabetes, so Latino, Native American, Asian American, or Black, if they are physically inactive, or they have polycystic ovarian disease. All of those put them at high risk and that we should screen them. So BMI with 1 risk factor or all of those that I just listed. So we would test her, or how would we test her? So there are several ways that we can test, and I did not do a slide for this, so I apologize. We can test her with a, there's a little bit of debate around this, but with a 50-gram oral glucose load, and then we test her blood 1 hour later. There's also, the American Diabetes Association recommends doing a 75-gram load and testing her 2 hours later because you capture more people that way. But the vast majority do the 50-gram, and if she fails that, then she comes back and does the 3-hour test. Your book in Varney talks about doing a hemoglobin A1C test, and if it's higher than 6.5 that we should consult with a physician. But I don't know anyone that uses that criteria. So for the most part, I think everyone does the 1 hour screen and then defaults to the 3 hour if she doesn't pass. There's some debate about what is the cutoff number for the 1 hour screen. Some people use 135 as the cutoff. Most people use the 140. Whatever you'll have to see whatever your clinic policy is. But at this point, I believe that most people use the 140 as the cutoff number. So for Jackie, her cutoff or her results were 160. So then, what would be the next steps that we would want to do? Well, as I said, we would send her for the 3 hour, and the criteria for a 3 hour is that you have to have, it's a 3 hour test, is you have 4 values. You have a fasting, a 1 hour, 2 hour, and a 3 hour value. And if 2 or more of those are high, then you are diagnosed as being a gestational diabetic. So that is what Jackie did, and here are what her results are. So if you look at that, she had a fasting that was high, her 1 hour was normal, and then her 2 hour was high, and her 3 hour was also high. So she actually had 3 results that were high, which would mean that she is diagnosed. And they put her on insulin, a sliding scale, carb counting, sugar checks, fasting pre-meal, 1 hour postprandial, and so 4 times a day checking her sugars. And she would see a dietitian. And so for that, yes, the correct, this is what we want all of our patients to be at when they are checking their glucose, whether they are fasting, whether on insulin or not on insulin, because it's important that they maintain good glycemic control. So usually what we do once we've diagnosed them is that we send them to a diabetes educator who will go through how to count carbs and how to change their diets. I recommend them that they play with the American Diabetes website because they have great diets set up that they can look at. And then the other place that I recommend is that they even go on Pinterest, and I kind of laugh when I say that, but there are some great meal plans that are out there, just some really good diet ideas that they can get. It doesn't feel so overwhelming to know that there are other people that are living and doing this and posting on Pinterest and on social media. And so I think it feels a little less overwhelming to know that other people have walked this road before you and that you can survive it. But they'll walk it through and show them how to use the finger sticks, how to test their blood. And then what we have to do, though, is when they see us, is that we have to go through with them and evaluate if they had highs, if they can explain why they had a high, if they know why. And usually if they have more than 2 or 3 highs in a week, then we need to send them back to the diabetes educator. And if they have more than 5, then it might mean that they need to be placed on insulin. And then at that point they become an MD patient, because typically that is not something that midwives manage. At that point they're too high risk for midwifery care. So therapeutic management, like we said, is we want them to have good preconception counseling, talking about before they get pregnant. They want to make sure that after that they have good blood glucose control. So at the postpartum visit, or even before they get pregnant, if we can take a hemoglobin A1C and make sure that they're staying in good control. These are all of the ways that we can help them manage their diabetes well. We need to do close maternal and fetal surveillance. We talked about that a little bit earlier. And we will have close management during labor and birth, but that's not something that we will cover during this presentation. So again, our health history is that we're going to do a good physical exam at our first OB visit, and we're going to evaluate all of our risk factors very carefully. Then determining on her risk factors will determine if we're going to screen her at our first prenatal visit. If we screen her at our first prenatal visit and she passes, we still do a second screen at her 28-week visit. Even if she passed that first one, she'll still get a second screen. Then we continue to do good maternal surveillance. We'll be checking her urine for protein and ketones. We don't necessarily do more than our normal, but we'll check that urine. We'll evaluate her renal function in each semester. We'll do an eye exam in the first trimester. We do a hemoglobin A1C, depending on what the endocrinologist is recommending, but usually at the beginning and in the third trimester. And then fetal surveillance, we do the level 2 ultrasounds. We'll do alpha fetoprotein levels. We do that antenatal testing as discussed. Amniocentesis only if indicated. We definitely want to do a fetal echogram with the level 2. So this is a picture of a baby. I wrote that it was Jackie's daughter, but we're gonna hope that she had good glycemic index, or good control. But this is a picture of an infant of a poorly controlled diabetic. So this baby is LGA, that has a very ruddy in color. The umbilical cord is really thick. You can't see that here, but typically their umbilical cord has a real thick consistency and a large placenta. And obviously you can see it's a very, you can see the stores, additional fat stores along the back. You can kind of see along here, but that reddish color is very common in patients that are diabetic with poor glycemic control. So I hope this lecture made sense, and if you have questions, kind of threw a lot at you here, but please let me know and post any questions you have in the general forum. Thanks so much.